So next I'll be talking on it.
Now I invite Dr. Anubhav Goyal, Senior Retina Surgeon at Giridhar Eye Institute, for the talk, case-based discussion on difficult PDR cases.
Thank you, sir. So my talk is on case-based discussion. So I'll be proceeding directly because this is a common general PDR scenarios where we can diagnose clinically very nicely. Right eye vitreous hemorrhage, FVP is left eye FVP. Need not to investigate. OCT is normal. Straight away start treatment. Or another scenario is when you have a suspicious hemorrhage in the one eye, another eye looking like NPDR. Go for angiogram, diagnose PDR, and start treatment. Treatment should be, in such cases, strict PRP laser covering all 4 quadrants from arcade till periphery. You should not leave or like a sectoral laser or minimal laser. You have to start PRP from the inferior quadrant in first sitting, because if the vitreous hemorrhage comes, then you will not be able to give PRP in the next sitting. It's a standard thing, and then complete in the second sitting. But what about in difficult scenarios, different scenarios, like when the right eye, here's right eye showing preparietal hemorrhage with edema, left eye CVNPD type of picture with dry macula. In such cases, you have to do angiogram. And if here right eye is showing NVE in superior quadrant and temporal quadrant, left eye is CVNPD picture. So give laser in right eye. NPDR as a protocol, as a studies, should not be treated until unless patient is non-compliant. In that case only you can give PRP, otherwise you need a close follow-up and treat accordingly. If left eye is also having PDR, diagnosed on angiogram, then obviously laser has to be considered as soon as possible. In a case which has fresh vitreous hemorrhage or resolving vitreous hemorrhage, you have to target a treatment accordingly, start PRP from the visible area like in superior quadrant, and then once the hemorrhage resolved, go to the less visible area. Already Dr. Jyoti has told that predominantly peripheral lesion is a very important lesion which can be seen clinically. You don't need to investigate. It's a very highly predictor of PDR on good indirect ophthalmoscopy. These are large blot hemorrhages which are highly predictor and can show you PDR changes, and you can treat accordingly. So role of anti-VEGFs, Dr. Ashok sir has already told. Protocol S shows that anti-VEGF works both good in anti-VEGF and laser works, both works very good in PDR cases, but it was just 2-year study. 5-year study shows that patient who has lost to follow-up and patient who has poor compliance, they did very poorly. So patient who underwent PRP laser did it well. Patient who get only anti-VEGF did it very poorly. So it's always good to give PRP in PDR cases, consider PRP more than anti-VEGF injection. Protocol T shows whatever injection you give, all are same, bevacizumab, ranibizumab, aflibercept, in 5 years down the line, all work same. You decide what you want to give. Yeah, in one case with a central involving DME, with poor vision in left eye, and both are clinically parietal hemorrhage with macular edema. Angiogram shows PDR in both eyes with 3 consecutive monthly dosing. Vision improved to 6.6 and edema resolved, and you see consequent angiogram shows complete resolution of NV. So in such cases where you don't have very fibrovascular polyps, no TRD, you can consider anti-VEGF initially in surface NV cases, and then later on you have to give PRP. It's not just anti-VEGF ending. There's a very good case with having a focal NVE. Angiogram shows massive NVs all around in both the eyes, and then initially treated with anti-VEGF, just one injection and all gone, and then laser was given. In patient with dense cataract, when you come to the OPD with macular edema, it's better to do angiogram as initial diagnosis. It's better for your understanding and patient understanding. If it is having any PDR, you can plan cataract surgery along with anti-VEGF, which will take care of edema also. An advanced PDR with 6.6 vision, this is a very good case. See, you can see right eye is having a 360-degree circular ring of TRD, but vision was 6.6, macula was on. Young lady, just observe her cases, they can do very well for many years without even treatment. This is angiogram showing a massive PDR in both the eyes with TRD right eye. Left eye was treated, right eye was just observed. There's a follow-up case of 2 years down the line with TRD and good vision in both the eyes, and patient was doing well. You see the OCT of right eye above and left eye below. If you see this third OCT scan of the left eye macula, it's automatically getting attached over the period of time. The right eye was maintaining dry in the macula. So such cases you can observe, and patient did well without adding any extra laser in long run. This is one video I want to show. Just PDR surgery are not always very easy to do. But then it's a surgery is needed when there's nothing else to be left, and you have a macular TRD and patient is poor. Patient needs it, you have to do it. But this has to be done as an end resort. It should not be the initial surgery, and it's a challenging surgery which can give good results, cannot give good results. So plan of diabetic retinopathy and preventing the patient to land up into surgical stage is most important. Try to avoid surgical stages. So this is ongoing surgery, segmented, all the membranes slowly removed, cauterized, and then I'll just fast forward and I'll show you the end result. So this was the end result of the patient with attached macula and vision improved from counting fingers to 618, 918. She is doing good with attached macula and reasonably good. So in patient with a few small area of TRD, gives scanty PRP away from the TRD. Patient who has circumferential TRD, peripheral laser only with scatter burns should be given, because laser can itself cause worsening of TRD, a crunch phenomena, which I'll be showing. Targeted PRP is a concept which was initially taken up by a lot of doctors. The quadrant where you are seeing NV, give laser and finish off. But patient, if it is lost to follow up, it does very poorly. The unlasered area can have TRD in long run only if patient is non-compliant. So it's better to finish off PRP rather than just giving PRP in one quadrant and following the patient if the patient is non-compliant. If patient is compliant, yes, targeted PRP is a good technique to sustain for long run. So there is no concept of prophylactic PRP in NPDR. Like in this patient, inferior PRP laser was done by some surgeon saying that you might need laser. Laser is indicated. There's no role, because you are killing a normal retina also with laser. It's a photocoagulation treatment. You should not give prophylactic PRP unless until you are confirmed that it's a PDR. So in a patient with cataract and other eye well lasered PDR and stable, it's always good to do OCT also, because you can plan surgery with a good planning prognosis postoperatively and for your better understanding of yourself and the patient. Patient with recurrent hemorrhage like this, which have 3-meter vision, then over time resolving vitreous hemorrhage vision improved to 618, then again recurrent hemorrhage 360 vision. They are patients who need vitreous surgery. You cannot treat them with conservative management. Anti-VEGF should be given with a lot of caution. Anti-VEGF is not the preferred treatment. So anti-VEGF should be avoided in advanced PDR with FVP and TRD, or can be given only and only when you are planning vitreous surgery in near future. Otherwise, these kind of cases, if you give anti-VEGF, they will end up into immediate worsening and gone. This is a crunch phenomenon. What I told is anti-VEGF on the left side, you see a small FVP, which was limited to the macula. After anti-VEGF, within 4 days, it increased. And if TRD also increased in macula, patient was taken for the surgery. So if patient having vitreomacular traction or ERM, even though you see edema, it will not improve with medical management. You have to do vitreous surgery. This is a post-op result of few other cases. The patient improved from 1 meter to 660 after surgery with attached macula. This is one Arabi boy, only 26 male, left eye no PL, right eye 1 meter vision, operated, and see the results 624 and 10. Good vision, good results, but these are not very uniform results. PDR surgeries are not always charming. They can have very variable results. But even one eye saved is a very, very good satisfaction for a surgeon to give a good night's sleep. Another case with 1 meter vision improved to 636. This is a massive 360-degree FVP, which also improved to 660 after the surgery. So take-home message is, PDR treatment is difficult, and treatment can be different in different hands. Even experts have bad experiences with best possible treatment. 5-year protocol says that PRP is the treatment for PDRs. Anti-VEGF can be given, but in only PDRs with surface NVs and FVP and TRD. PRP is the treatment and should be targeted accordingly. Anti-VEGF should be avoided in PDRs, and it's a personal choice which anti-VEGF to be given. Lasers is preferred treatment, but for advanced PDRs with macular traction, vitreous surgery is a preferred option. Thank you, sir.
Thank you, Anubhav. 1 or 2 points here. As Dr. Anubhav said, for PDR, PRP is the gold standard. Okay. And second thing, when you have some prolifs and all that, better don't give PRP on the prolifs. You give the laser maybe 1 to 2 disc diameters away from the prolif.
Away from the prolif.
Then extensive prolif, don't give massive PRP in 1 or 2 sittings or 1 sitting. You give little bit so that, it takes up and the retina stabilizes. And the third thing is when you have PDR with DME, see, we do cataract surgery along with anti-VEGF agents. The combination of anti-VEGF with cataract is an off-label use of anti-VEGF. Anti-VEGF agents is not really approved to be used along with cataract surgery. But if you look at dexamethasone implant, there is an FDA approval for using dexamethasone implant along with cataract surgery. So these points come when you have a cataract surgery along with an anti-VEGF and patient develops end-off and goes for a litigation. Now they will ask you why you gave anti-VEGF along with cataract when it is only an off-label use. How do you explain that to the patient? So these are some things in mind you have to keep before you decide on therapy.
Thank you, sir.